Welcome to the May 2016 podcast from the Journal of Bone and Joint Surgery. This month, our podcast features abstracts of 4 scientific articles published in the May issues of the journal, as well as commentaries by Dr. David W. Manning on the article entitled Trend Toward High-Volume Hospitals and the Influence on Complications in Knee and Hip Arthroplasty, and Dr. Marvin E. Steinberg on the article entitled Percent Body Fat is More Predictive of Function After Total Joint Arthroplasty Than Body Mass Index. Be sure to check out this month's Current Concepts review article on HIV and Orthopedics, Musculoskeletal Manifestations and Outcomes by Dr. Juan Pratalazzini and colleagues. The authors note that advances in combined antiretroviral therapy in recent years have transformed HIV infection into a chronic disease when treatment is available, increasing a patient's life expectancy and the chances that orthopedic surgeons will encounter such patients in their clinical practice. Musculoskeletal manifestations in patients with HIV infection are common and sometimes are the initial presentation of the disease. As knowledge about neoplasms and associated conditions affecting muscle, bones, and joints is essential for successful management, this article reviews the relevant literature on the most prevalent musculoskeletal manifestations and surgical outcomes in the HIV-positive population. In this issue, JBJS.org presents a new image quiz, an 8-year-old girl with increasing thigh and groin discomfort. Be sure to visit us online to access these features, as well as the full text of the scientific articles you are about to discover in the following podcast. Next, you'll hear the first abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Trend Toward High-Volume Hospitals and the Influence on Complications in Knee and Hip Arthroplasty by Dr. Nicholas C. Lausis and Associates. Investigation performed at the Clinical and Investigative Orthopedic Surgery Unit, National Institute of Arthritis and Musculoskeletal and Skin Diseases, National Institutes of Health, Bethesda, Maryland. Hospitals in which a high volume of arthroplasty procedures are performed have been observed to have better outcomes. As the number of arthroplasties has increased, it is not known whether surgical cases have shifted to high-volume hospitals. In this study, the authors examined the change in the volume of arthroplasties to provide a contemporary definition of high-volume centers, quantified surgical volume that shifted to high-volume centers, and investigated the resulting effect on complications. Data from the National Inpatient Sample were used to quantify trends in total hip arthroplasty, THA, and total knee arthroplasty, TKA volume. Elective primary THAs and TKAs were identified and grouped by hospital by utilizing the hospital identifier, which indicates the geographic location of the hospital. County geographic and population data were obtained from the U.S. Census, and the distances between hospitals and the centroids of counties were calculated. Risk-standardized surgical complication rates for hospitals were obtained from Medicare Hospital Compare and grouped by hospital volume. From 2000 to 2012, there was a marked increase in the number of hospitals that performed a combined volume of greater than or equal to 400 elective primary THAs and TKAs. The number of elective primary TKAs and THAs performed annually increased from 343,000 to 851,000. In 2012, 65.5% of the arthroplasties were performed in high-volume hospitals, and 26.6% of the arthroplasties were performed in very high-volume hospitals. The proportion of arthroplasties performed in low-volume hospitals shrank from 17.9% to 5.4%. Very high-volume hospitals had the lowest complication rates, and low-volume hospitals had the highest complication rates. The analysis showed that 81.9% of the U.S. population lived within 50 miles of a high-volume hospital. Conclusions. Arthroplasty patients are electing to have their procedures at higher-volume hospitals in the United States. Each successively higher hospital volume category manifested a lower complication rate. Next, you'll hear a commentary by Dr. David W. Manning on the article entitled Trend Toward High-Volume Hospitals and the Influence on Complications in Knee and Hip Arthroplasty.
This is Dr. David W. Manning, providing commentary for the May 2016 JBJS podcast. I will be providing commentary on the article entitled Trend Toward High-Volume Hospitals and the Influence on Complications in Knee and Hip Arthroplasty. The title of my commentary is Volume and Quality in Total Joint Arthroplasty, a Complex Relationship. Total joint arthroplasty is an extremely high-quality medical intervention with measured benefit to individual patients and society as a whole. In the current healthcare climate, the volume of procedures performed and expected to be performed in the near future has created a fiscal strain that has subsequently brought increased scrutiny and oversight to the critical assessment of arthroplasty outcomes and its associated costs. Health systems, third-party payers, individual institutions, and physicians are grappling with how to best structure the provision of quality care and meet patient demand for the procedure at the lowest overall cost, thereby optimizing the value proposition. There are many examples of a volume relationship to excellence in industry, finance, and healthcare. Several investigators have attempted to identify such a relationship within total joint arthroplasty and in general have shown, depending on the metric of interest, that volume is related to quality. In separate investigations of hip and knee arthroplasty, Katz et al. Showed that surgeons and institutions with higher annual caseloads had lower incidences of costly adverse events and selected complications. Such information has bolstered arguments made by some for the regionalization of total joint arthroplasty to large care centers as a strategy to both meet demand and optimize value. Within this context, there is merit to the concept of regionalization. However, short-term complications are not synonymous with outcome and certainly do not reflect the patient outcomes of interest that have proven arthroplasty to be a quality intervention over time. It would seem that universally agreed upon and statistically valid patient-reported outcomes following total joint arthroplasty would better serve such policy decisions. The volume-quality relationship in total joint arthroplasty, as in healthcare in general and industry at large, is quite complex and not fully understood. Little investigation has been performed to fully elucidate this complex relationship in arthroplasty care, so we must look to other fields in medicine for guidance. When reviewing the relationship between surgical volume and mortality in the setting of congenital heart disease, Preston et al. Noted that a relationship between volume and outcome exists and is greatest for low-frequency conditions, but is unlikely to be a simple, independent, and directly causal relationship. Our report from the National Academies found that the volume-quality relationship in cancer care was an imperfect correlation, and also noted that the relationship was strongest for low-frequency, high-complexity surgical conditions such as pancreatic cancer. Certainly, it is difficult to apply these observations to a high-volume condition such as total joint arthroplasty. Several key questions remain unresolved regarding the volume-quality relationship. 1. Where along the continuum of volume does a threshold exist at which outcome no longer improves with increasing volume? 2. If a threshold is determined, might it change over time? 3. How do surgeon and institution volumes combine and interact? 4. What is the distinct role of clinical process improvement that is innately tied to managing increased volume? 5. Once high volume is attained, must it be sustained to preserve the related performance benefit, and what is the rate of decay, if any? With respect to the final 2 points, Kuo et al. Identified process quality to be significantly more related to recurrence and survival following breast cancer surgery than was procedural volume. The current article by Lausis et al. Attempts to identify trends in case volume from 2000 to 2012 among high, intermediate, and low volume centers, offer a new definition of high volume, and examine the effect of procedure volume on complications. To these ends, the investigators utilized 3 separate and statistically unrelated data sets: the national inpatient sample from 2000 to 2012, the 2010 U.S. Census, and the Centers for Medicare and Medicaid Services Hospital Compared Database from 2009 to 2012. Although the study was not a mechanistic investigation, the authors did make some interesting observations. First, they observed, as others have, a staggering growth in arthroplasty utilization in the United States. They were also able to document in the NIS dataset a general shift in primary arthroplasty procedure volume to institutions performing greater than 400 arthroplasties annually, with a corollary decrease in the volume of procedures performed at low-volume institutions over the time period studied. Their findings appropriately support redefining what it means to be high volume, and the authors introduced the term very high volume institution to distinguish those performing greater than 1,000 procedures annually. Furthermore, they noted that 81.9% of the U.S. population lived within 50 miles of an institution performing greater than 400 procedures annually, perhaps indicating a de facto regionalization of care. The authors attempted to draw conclusions regarding the volume-quality relationship via reporting Centers for Medicare and Medicaid Services hospital compare data, indicating that very high volume institutions had the lowest reported complication rate. However, the authors could not identify a tipping point in the relationship between volume and quality and could not rectify the disparity between the publicly reported short-term complication rate in a Medicare-only population and a more valuable and encompassing definition of outcome. In addition, it is clear that data sets such as hospital compare are subject to physician bias regarding the timely diagnosis and reporting of complications, as most aptly identified by Bill Amoria et al. Regarding the diagnosis of post-surgical venous thromboembolism. The authors of the current investigation are also unable to draw a conclusion regarding the effect of publicly available complication data on the observed volume shift because of the very different time points of observation. With regard to arthroplasty care in the United States, we are at a crossroads. The fiscal environment necessitates action in order to preserve patient access to quality, affordable care, and institutions, providers, payers, and policymakers are grappling with what constitutes the best strategy. A volume-quality relationship seems to exist and would support regionalization of care as a strategy to manage costs and quality, but that relationship is not fully understood. In addition, it has been argued by some that the strategy of regionalization may have the unintended consequence of penalizing at-risk populations. Conversely, if the relationship between volume and quality is clarified and the tipping point is near 400 procedures annually, then the vast majority of the American public, as the current article suggests, is near enough to a high-quality center that no active effort regarding regionalization is warranted. Dramatic increases in national arthroplasty utilization and market pressures over the last decade have created a de facto regionalization policy. Continued investigation regarding the combined effects of process improvement and surgeon and institution volume, perhaps supported by patient-reported outcome data from national registries, is warranted and desired so that we might craft the best plan to provide quality arthroplasty care to our aging population.
Next, you'll hear the second abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Predictive Factors for Differentiating Between Septic Arthritis and Lyme Disease of the Knee in Children by Keith D. Baldwin and Associates. Investigation performed at the Children's Hospital of Philadelphia, Pennsylvania. Differentiating between septic arthritis and Lyme disease of the knee in endemic areas can be challenging and has major implications for patient management. The purpose of this study was to identify a prediction rule to differentiate septic arthritis from Lyme disease in children presenting with knee pain and effusion. The authors retrospectively reviewed the records of patients younger than 18 years of age with knee effusions who underwent arthrocentesis at the author's institution from 2005 to 2013. Patients with either septic arthritis or Lyme disease were included. To avoid misclassification bias, undiagnosed knee effusions and joints with both a positive culture and positive Lyme titers were excluded. Historical, clinical, and laboratory data were compared between groups to identify variables for comparison. Binary logistic regression analysis was used to identify independent predictive variables. 189 patients were studied, 23 with culture-positive septic arthritis, 26 with culture-negative septic arthritis, and 140 with Lyme disease. Multivariate binary logistic regression identified pain with short arc motion, history of fever reported by the patient or a family member, C-reactive protein of greater than 4 milligrams per liter, and age younger than 2 years as independent predictive factors for septic arthritis. A simpler model was developed that showed that the risk of septic arthritis with none of these factors was 2%, with one of these factors was 18%, with 2 of these factors was 45%, with 3 of these factors was 84%, or with all 4 of these factors was 100%. Conclusions. Although septic arthritis of the knee and Lyme monoarthritis share common features that can make them difficult to distinguish clinically, the presence of pain with short arc motion, C-reactive protein of greater than 4.0 milligrams per liter, patient-reported history of fever, and age younger than 2 years were independent predictive factors of septic arthritis in pediatric patients. The more factors that are present, the higher the risk of having septic arthritis. Next, you'll hear the third abstract of 4 that are being presented in this podcast. This abstract is from the article entitled "Percent Body Fat is More Predictive of Function After Total Joint Arthroplasty Than Body Mass Index" by Dr. Cameron K. Ledford and Associates. Investigation performed at the Department of Orthopedic Surgery, Duke University Medical Center, Durham, North Carolina. Obesity has an important impact on the future of total joint arthroplasty. However, the definition and influence of obesity on surgical risks and outcomes remain controversial. The author's hypothesis was that percent body fat was better than body mass index, BMI, at identifying clinical risks and patient-reported functional outcomes following arthroplasty. Clinical and functional outcomes were collected prospectively in 215 patients undergoing primary total knee arthroplasty or total hip arthroplasty at a mean time of 24 months. Clinical data included patient demographic characteristics, preoperative evaluation including measurements of BMI and percent body fat, intraoperative records, hospital course or events, and postoperative outpatient follow-up. Patient-reported outcomes were obtained through a series of questionnaires, a surgical satisfaction survey, the University of California Los Angeles Activity Scale, the Knee Injury and Osteoarthritis Outcome Score for Total Knee Arthroplasty, and the Hip Disability and Osteoarthritis Outcome Score for Total Hip Arthroplasty. Multivariable regression models were used to identify significant body mass predictors of outcomes. Higher percent body fat predicted occurrence of any medical or surgical complication. Percent body fat was also a predictor of the UCLA Activity Score and pain scores, and it trended toward significance for the surgical satisfaction score, whereas BMI was not predictive of these functional outcomes. Additionally, with regard to surgical procedure-specific outcome scores, percent body fat was predictive of outcomes after total knee arthroplasty, but not for those after total hip arthroplasty. Conclusions. Percent body fat should be considered when predicting clinical and functional outcomes at 2 years following total joint arthroplasty. Percent body fat may help surgeons to improve risk stratifications, to project patient-reported functional outcomes, and to better educate obese patients with regard to postoperative expectations prior to undergoing elective total joint arthroplasty. Next, you'll hear a commentary by Dr. Marvin E. Steinberg on the article entitled "Percent Body Fat is More Predictive of Function After Total Joint Arthroplasty Than Body Mass Index."
This is Dr. Marvin E. Steinberg providing commentary for the May 2016 JBJS podcast. I will be providing commentary on the article entitled "Percent Body Fat is More Predictive of Function After Total Joint Arthroplasty Than Body Mass Index." The title of my commentary is there a role for body fat determination in total joint arthroplasty? It is well established that obesity can have a serious impact on health, including coronary artery disease, hypertension, diabetes, and mortality. The relationship between obesity and outcome following total joint arthroplasty, however, is less clear. Although severe or morbid obesity can result in increased complications and poor functional outcomes, mild to moderate obesity has a relatively small effect that may not be clinically relevant in view of the marked benefits that most patients derive from total joint arthroplasty. This underscores the importance of determining the degree of obesity present and using the most effective methods to make this determination. The current standard is the Body Mass Index, or BMI, which is based on the relationship between height and weight, and which allows patients to be classified into 5 categories. BMI may be a satisfactory proxy for obesity or body fat percentage, but it has several limitations, including its inability to differentiate among bone, muscle, and fat mass. A more accurate measurement of body fat can be obtained using bioelectric impedance analysis, as described by Ledford et al. And other authors. However, an important question is whether this provides a more accurate method of predicting outcome following total joint arthroplasty. Ledford et al. Have evaluated both clinical and patient-reported functional outcomes of 215 patients at a mean time of 24 months after primary total hip arthroplasty or total knee arthroplasty, using standard outcome measures. They calculated BMI using height and weight and determined percent body fat using bioelectric impedance analysis. Both BMI and percent body fat were then correlated with several outcome measurements for each patient. They found some degree of correlation for both BMI and percent body fat, but a greater degree of correlation between percent body fat and functional and clinical outcomes. The greater the obesity, the poorer the outcome. They concluded that percent body fat should be considered when predicting clinical and functional outcomes 2 years following total joint arthroplasty. Ledford et al. Have conducted a careful prospective study and have used a novel approach to determine obesity on the basis of bioelectric impedance analysis to measure body fat. This provides us with information not previously available. Although they found that the percent body fat predicted outcomes following total joint arthroplasty better than BMI, the differences between these two techniques were not significant for every parameter of evaluation. A relatively small number of patients were present in each category, and the low number of joint-specific complications made analysis difficult. They did not specifically classify patients on the basis of the degree of their obesity, which might have yielded some interesting information. Even if percent body fat determination proves to be a better indicator of obesity than BMI, we have yet to evaluate the clinical importance of this observation. In addition, it does require the use of special equipment and techniques. Severe or morbid obesity does affect outcome after total joint arthroplasty, but this can probably be determined effectively using either method of evaluation. Lesser degrees of obesity may not substantially detract from outcome, and more accurate methods of determining obesity in these patients may have little clinical value. Ledford et al. Have presented us with a novel and interesting approach to this problem and have perhaps left us with more questions than answers. How will the information provided affect the care of patients who are candidates for total joint arthroplasty? In addition to considering the role of percent body fat measurements in total joint arthroplasty, this technique might have a much broader application in evaluating a number of obesity-related medical conditions. Further studies along these lines are therefore warranted.
Next, you'll hear the last abstract of 4 that are being presented in this podcast. This abstract is from the article entitled Are Outcomes for Hip Arthroscopy According to Sex and Age? A Comparative Matched Group Analysis by Dr. Rachel M. Frank and Associates. Investigation performed at the Department of Orthopedic Surgery, Rush University Medical Center, Chicago, Illinois. Factors such as age and sex are postulated to play a role in outcomes following arthroscopy for femoral acetabular impingement. However, to the author's knowledge, no data currently delineate outcomes on the basis of these factors. The purpose of this study was to compare clinical outcomes of patients undergoing hip arthroscopy for femoral acetabular impingement according to sex and age. 150 patients undergoing hip arthroscopy for femoral acetabular impingement by a single fellowship-trained surgeon were prospectively analyzed, with 25 patients in each of the following groups: female patients younger than 30 years of age, female patients 30 to 45 years of age, female patients older than 45 years of age, male patients younger than 30 years of age, male patients 30 to 45 years of age, and male patients older than 45 years of age. The primary outcomes included the Hip Outcome Score Activities of Daily Living Subscale, Hip Outcome Score Sport-Specific Subscale, the Modified Harris Hip Score, and clinical improvement at the time of follow-up. At a minimum 2-year follow-up, all groups demonstrated significant improvements in the HOS-ADL, the HOS Sport, and the MHHS. Female patients older than 45 years of age scored significantly worse on the HOS-ADL, HOS Sport, and MHHS compared with female patients younger than 30 years of age and female patients 30 to 45 years of age. Male patients older than 45 years of age scored significantly worse on all outcomes compared with male patients younger than 30 years of age and male patients 30 to 45 years of age. Incorporating both sexes, patients older than 45 years of age scored significantly worse on all outcomes compared with patients younger than 30 years of age and patients 30 to 45 years of age. Female patients older than 45 years of age had significantly reduced radiographic preoperative joint space width compared with the two other female groups and the male groups who were 45 years of age or younger. Conclusions. Although all patients had significant improvements in all outcomes following hip arthroscopy, patients older than 45 years of age performed worse than younger patients, with female patients older than 45 years of age demonstrating the lowest outcome scores. In the age group of 45 years or younger, female patients performed as well as male patients in terms of hip clinical outcome scores. Overall, care must be individualized to optimize outcomes following hip arthroscopy for femoroacetabular impingement. Thank you for listening to this JBJS podcast. Please visit www.jbjs.org for commentary and perspective on many of the articles presented in this podcast, and for more content of interest.